I'd like to welcome Dr. Sasha Blaskovich back today.
Thanks for having me, Athena.
Welcome, Dr. B. In this session, we'll be generating awareness as to the prevalence of neck disorders and craniocervical issues and how they span across many patient groups. So let's begin by speaking about the most obvious group, which is physical trauma, motor vehicle accident or other, and where there's a direct link of causation and the area of injury is clear. Can you speak to some of the patients that you see and the nature of their injuries?
Definitely. So the vast majority of patients present that have been in automobile collisions, the most common being a rear end collision. So they've been hit from behind, and then other variations from the side, frontal, turning. And then the next most common demographic that we get to see are athletes that have either sustained a hit or a fall. And the worst case scenario for all those groups is when they're not braced and prepared for the impact. So when they're unsuspectant, and one of the biggest, I think, misconceptions globally as far as the patient crowd is concerned is that a lot of patients and people, and even physicians, believe that if you're in a relaxed state, you're better off and you're going to injure less. Unfortunately, it's the exact opposite of that. So the more braced you are for an impact, so if you're suspecting you're going to get rear-ended or you're suspecting you're going to get hit from behind as a quarterback, for example, and you brace for that impact, you might initially have more symptoms because you've now strained a lot of muscles that are trying to guard for that impact. But muscles are perfused with blood and they have a capacity to heal, and they have a great capacity to heal. But if those muscular tissues are overridden and you get tension put on the ligaments and those ligaments fail either partially or fully, this is the case where you will have initially some symptoms, but those symptoms will continue to either be present or worsen over time. And those are generally the chronic patients that and people that we get to deal with, is the people who weren't braced for an impact, but yet continue to have these issues because in their impact, they usually damage ligaments and not muscles. So they end up sustaining sprains, which relate to ligamentous tissue and cartilaginous tissue, instead of strains, which relate to muscular tissue. And so when a person gets a diagnosis that we often see, they had a cervical sprain strain. That is not a very good diagnosis because it doesn't actually tell you. It assumes that everything has happened, and it usually has. But the questioning and the knowledge of where they brace, where they're not braced, would dictate more accurately whether they sustained more likely a sprain or a strain. And then you can use, clinical testing and imaging to confirm those things.
Yes, I share that in that my case was being involved in a high-speed motor vehicle accident, T-boned. And so the consequences were significant, and it was not visible. It was 4 lanes over, not visible. So the consequences were significant. So I appreciate that example. Do you want to speak also about your personal experience with your concussive type of injuries and what your findings were thereafter?
So concussive injuries can either occur whether you have direct contact, so the blow to the head, or the head impacts either onto the ground or onto an object. I mean, you have people passing out, going to the bathroom in the middle of the night and smashing their head into the wall as they fall, creating a concussive type scenario. But whenever you have momentum related trauma, so impacts that come at certain speeds, which most of these do, whether you impact the head or not, there are acceleration and deceleration factors involved. And so it's, at least in my humble opinion, it's impossible to separate out and say just the brain was affected and the skull was affected by this event, and omit or neglect to include the neck in that, and vice versa as well. So if somebody says, I sustained a whiplash, well, that motion involves the head as well. That's the tip end of the whip. And so you have to affect the structures inside that end of the whip or the skull. And so the head and the neck cannot be separated no matter what kind of a whiplash or concussive impact or blow that you have. And that brings me to the most important point, I think, that we've been focusing all along, is that the junction point of those two structures between the head and the neck is that transition zone where the neck connects to the head. And that's by far the most overlooked or evaluated and under-assessed region when it comes to patients that have either sustained a concussion diagnosis or sustained a whiplash diagnosis, is that the junction point is not has not generally been of great importance. And so again, the brain gets a lot of attention, and the discs lower below the junction point between the skull and the neck get a lot of attention, but not that junction point, unfortunately. And so that's, I think what we're trying to accomplish with these sessions is to put a lot of onus and focus on the area that has generally been neglected in diagnostics and in getting the proper attention for being a potential part of the problem.
Thank you. That's very critical. And as we'll come to speak today in our different multitude of patient groups, we'll see that the head and the head and the neck are a critical component to be evaluated, not exclusive one or the other in terms of diagnostics. So I think that's very relevant what you mentioned. So let's turn our attention now to another patient group, Down syndrome, where a congenital abnormality results from an extra chromosome, and this can impact the biomechanical structure that results in an increased risk of developing compression to the spinal cord. Do you have some thoughts regarding this group?
Yeah, so there, at least when we went through our education in our school, they were the group that were alluded to in addition to rheumatoid arthritis, the rheumatoid arthritis group, but the Down syndrome group as a collective having the propensity to have an anomaly, so an abnormality in the ligaments structures at the craniocervical junction, rendering their upper cervical spine unstable as a genetic byproduct of that chromosome abnormality. And so they're a demographic or a group of individuals that have been studied as far as it pertains to some of the neurological manifestations that they have as being caused by the laxity that they have in their upper cervical ligament anatomy, causing brainstem irritation.
Yes, and the prevalence of CCI in this group of patients has been noted to range up to 63% in the literature of this particular patient group.
Yeah.
Next, let's talk about Ehlers-Danlos syndrome, referred to often as EDS. In 2016, the Journal of Spine, Dr. Henderson referred to CCI in patients with hypermobility and connective tissue disorders, and this prevalence has been well documented. Moreover, the past few years, there's a clear understanding that's evolving that not every person in the EDS community will go on to develop CCI. However, if a patient goes on to develop craniocervical issues, this pushes the problem closer to CCI. That is, it's a contributing factor. And that was actually just discussed last week with Dr. Kaufman. So that last piece is Dr. Kaufman's words, not mine.
Mm-hmm.
Do you want to speak to this issue?
Yeah, absolutely. I mean, you can have a connective tissue disorder like EDS and not have CCI, because ultimately EDS should be affecting the entire being. And, barring trauma to the cervical spine, I believe that EDS patients, so people who have the genetic version of EDS, because of the ligament laxity that they have globally, they're going to have laxity everywhere. But when you then add to that, mix a trauma that is focused, or the focal point of that trauma is the head and the neck, so either a concussive or a whiplash type trauma, because of the already lax structures there, you're going to have the ability or the propensity to have a more significant injury to the further injury, I guess, to those ligaments, resulting in CCI. So having EDS is not a sealed case as to you're going to get CCI. I think there are factors that come extrinsically to having EDS that would increase the risk, I guess. I don't think anything's certain, but increase the risk of developing CCI or AAI as a result of either a major trauma or multiple minor traumas that cumulatively summate to give you what would be considered a macro trauma, but yielding the CCI or AAI. Absolutely.
And I would add that if a trauma did not exist, or a series of micro traumas did not exist, what has pushed the needle a little closer for this type of patient? In other words, does infection or other play a role? And that's something that I've done personal research on as well. So it's just a question that perhaps this community could ask. So I want to speak about the overlap. Some neurosurgeons have indicated that EDS patients and ME/CFS patients are directing treatment in the same manner with regard to craniocervical instabilities. So I would argue that this brings this patient group closer together and patient groups closer together.
I
It's an
definitely think
opportunity.
there's a massive overlap between all the different named diagnostic conditions, which are often, like I alluded to in a previous session, labeled by the description of their symptoms as opposed to the causal tissue being diagnosed. And so I do think there's a lot of overlap that occurs between all the different diagnostic groups that relate to what would be deemed CCI or AAI.
Thank you. Next, let's speak about rheumatoid arthritis, which you alluded to, and systemic lupus included. Case reports in AME in 2021 detail autoimmune diseases that affect synovial tissue, which lines the joints and tendons. And the CCJ we know is made up of synovial joints and ligaments, which are especially vulnerable to rheumatic arthritic and other inflammatory processes.
Correct. Yeah. So the erosive nature of the inflammation caused by these autoimmune conditions, and I think they can all be lumped into there to a degree, but I think the most studied has been RA, rheumatoid arthritis, and I think lupus probably comes as a close second. But then you have Sjogren's, psoriatic arthritis, the ulcerative colitis, the group of digestive ones, ankylosing spondylitis, which technically fuses things but can also damage ligaments. As a collective group, I think it's the systemic inflammation that causes erosion of ligaments. And because of the fact that the craniocervical junction is so relevant to body-wide functioning, because it does house the medulla and the beginning part of the upper spinal cord, the interrelation between that area being affected by the instability then or hypermobility that is caused by the erosion of the ligaments there due to these inflammatory conditions will result in neural compromise, I guess, resulting in a cascade of symptoms that, in addition to the RA, could be labeled as POTS or dysautonomia or ME/CFS or a number of other things.
Interesting that you raised this. Dr. Ruhoy, I want to say, recently, maybe a week or two ago, posted regarding the medulla and the role that it plays in autoimmune conditions and the inflammatory piece. So it's very much in line with what you're saying.
Well, if you
So
look
the
up what
article,
the vagus nerve is responsible for, part of that is immunity.
right. So recent estimates suggest that up to 86% of RA patients have radiological evidence of cervical spine involvement. That is almost everyone in this
Yes.
group of patients. So next, let's turn to the myalgic encephalomyelitis, ME/CFS community. In 2021, this is kind of an interesting story. I guess you could say this is part of my story. In 2021 I wasn't receiving any questions, any responses to questions in Canada. I ventured to US-based ME/CFS groups, which included championing physicians such as Dr. Kaufman, Dr. Ruhoy, and so on. I was asking questions about the craniocervical issues and CCI and multi-patient groups that I was noticing as I was coming across them in clinics. And Dr. Kaufman was kind enough to respond to that regarding the overlap. I've posted that actually in my website, which is focusonhealing.ca. But I want to say that this response was a pivotal moment for me and what would change the trajectory of my life through serendipity and a passion, where I suspected that this overlap existed in multi-patient groups. And I started to do my research from the floor for 2 years. So in 2018, Dr. Rowe published a case series detailing the improvement of ME/CFS patients in stenosis as a resolution to symptoms. Now, I just want to say that these patients had tried many other medications that were non-invasive and therapeutics. So these patients had been treated surgically, and their symptoms were in the small group, the case symptoms had resolved. Any thoughts in terms of ME/CFS patients?
What kind of surgery did they have?
It was directly related to stenosis in a small group. It's a good question. There is an
because
article
you can have bony stenosis at all levels in the cervical spine, but you can also have, which is an anatomic stenosis, and you can also have functional stenosis. And the functional stenosis generally is caused by an excessive. So if the bones, these are two bones, and they're supposed to be stacked properly so that the canal between there is fully open. But when you have ligament laxity, because these are movable entities, you can have translation where what's going through that opening there is the spinal cord and brainstem, which will be stenosed upon or narrowed upon by that excessive shift when ligaments are damaged. So if they were doing, I guess, fusion surgeries to mitigate the instability, which would then take away the functional stenosis, makes a ton of sense. And again, if they're, people who have developed arthritic stenosis due to bone spur formation inside a fixed canal, I would imagine, decompressing that would have the same effect. So it still all boils down to either brainstem or spinal cord compression as a result of either a bony narrowing, which is an anatomic phenomenon, usually due to extra growth within the canal, or a functional phenomenon where there's no extra growth, but you have excessive shift causing the stenosis.
I will check to see if it was. I don't believe they refused, but I don't want to quote that. I will go back to the article, and I believe it is posted on the site in terms of the procedure that was done. Let's turn to brain and neck disorders, which I feel like we've been talking about throughout our discussions, but let's kind of refocus. Let's use MS Canada as an example, multiple sclerosis, MS, and talk about CCSVI, which is chronic cerebrospinal venous insufficiency. And a theory that's used, which was heavily investigated with significant investment dedicated to the veins in the head and the neck being narrowed or blocked, and pressure caused by the buildup of the blood causing reflex into the central nervous system through new blood vessels. So this has been studied as a theory to MS patients. Can you comment on that? I also want to say I did see your video with Matt Embry on your YouTube channel.
Thank you. Yes. This dates quite a ways back. I recall when I was still practicing in Europe that I remembered hearing about a guy named Dr. Zamboni in Italy, and there were people going from literally everywhere in the world with MS to him for vascular decompressive surgery and remitting their MS, at least for a period of time. And what I notice, or what is noticed a lot when looked for with CCI, AAI patients, when they're either having contrast MRIs or regular MRIs that for great purposes show vasculature, is that the internal jugular vein tends to be a common entity that looks like it's compressed. And so you have drainage issues, again, possibly because of that functional stenosis that I was talking about, because these vascular structures are in very close proximity to the C1 transverse processes, or these things that stick out on the edge of C1 right here. And so when you have instability or hypermobility, where you could have a quote unquote malposition of C1 at any given time, where it comes closer to vascular structure, the compressive forces of that could cause decreased flow or decreased perfusion, depending on which structure it is. So if it's an arterial structure, delivering blood, it can reduce the perfusion. And if it's a venous structure that's draining blood, it could reduce the drainage. And in both cases, you could have an effect of that. And so with the MS category of patient, the notion has been shown that the vast majority of their sclerotic plaques, or these scarred plaques that have been perceived to be dead brain tissue or severely affected brain tissue, are surrounding the ventricles. And these are the areas inside the brain that make cerebrospinal fluid. So when you have your heartbeat, it beats blood through your entire body, but it also beats it around the head. And there's this cheesecloth that surrounds the brain called the blood-brain barrier. And the fluid out of that blood that's beating gets across that blood-brain barrier membrane, and then the brain makes CSF from that inside the ventricles. And then that CSF is supposed to then circulate and drain through the upper neck in through the rest of the spinal canal, and all gets reabsorbed as that circulation concurs. And so when you have a functional stenosis, let's say, you can have a narrowing of both the drainage, but also the perfusion, causing basically a backup into the skull. And the first place that it would back up into is where it's being made. So the ventricles would distend a little bit. And as they distend, the brain tissue adjacent to that would get squished a little bit, because the skull is a fixed entity. It's not going to give at all. So as you start expanding those ventricles, you could squeeze down and reduce the perfusion, if you will, or the delivery of blood with oxygen and nutrients in it to the adjacent brain tissue, causing some of those tissues to go into a less metabolic state. and occasionally will then turn into what looks like a sclerotic entity on an MRI. And it's not necessarily always a dead piece of tissue, because Dr. Damadian, which I think we touched upon last time, he's actually studied this where they've looked at malpositions of the atlas as a potential causal factor when they do the CSF flow analysis with the upright MRI there, and noting that a malposition of C1 is part of the reason why there's a kink in the CSF flow at a certain junction point. And when you realign C1, that kink becomes fluid again. And so then the pressure inside the ventricles equilibrates to how much is being drained out of there. And you have less expansion of the ventricles, or if they've already been expanded, they will compress back down to a normal size, causing that brain tissue that was slightly squished by them, which form then sclerotic plaques, which are visible on MRI, would then get less pressure on it, and the perfusion would increase to that tissue, and some of these plaques would actually disappear. And the reason that they would disappear is, he believed, Dr. Damadian believed, that they were actually in a hibernative state due to these compressive forces, due to the CSF flow abnormality and the kinking, that when you took away the kinking, you restored the dynamics of the fluid circulation inside the brain and spinal canal, whereby you reduced then the size of the ventricles, reducing the pressure on that brain tissue adjacent to it, where normally, like I said, the plaques are normally seen on MRI as periventricular, thereby yielding a remission, if you will, or a reduction in the number of plaques seen. And a lot of those patients, the plaques would return, and ultimately, because there's instability there, you'll have a malposition, changing that fluid dynamics, causing a narrowing of the drainage, and then a backup and expansion. And so you get a vicious circle with all that could, in a lot of cases, be mitigated by simply repositioning the atlas, for example.
Funny story. I was one of the fortunate patients who did have the opportunity to have that study done through upright MRI that you just discussed. And after the alignment, I did have an AO alignment immediately after, and was imaged with the CSF flow study. It was very clear that the drainage was not working properly, and my heart rate changed and was altered by 20 beats per minute after the alignment. So pretty significant. I've actually visually seen what you just described in technical content.
Very significant. But again, like I said, when the correction is done and you have a restoration of all these things, and then it reverts back and becomes, dysfunctional or abnormal again, the number one question that should be crossing anybody's mind who's a physician dealing with this is, are we dealing with instability? Is it not just a positional thing? Because if you have instability, you could have an out of position thing at any given moment. Even right after you've been repositioned, it could malposition again.
That's where we refer to the persistent misalignment, and we will talk about some of the techniques
Right.
that we'll be using for the to resolve and try to support the alignment to ensure that it does hold for longer.
Right.
I want to say as well, Dr. Ferdinand Huey, which I believe was out of Johns Hopkins, who was a neuroradiologist, has recently formed a team. He's organized a team of neurosurgeons, neurologists, and neurointervention panelists. This was recently done in 2023, and he speaks to many of the brain and neck disorders, including venous congestion, hypotension and hypertension, intracranial, and so on. So there's also a current meeting that they've shared, a team meeting that they've shared. So there's some work and attention being garnered towards this. And this is actually based on patients that they've lost when they had no solutions for them. So sad stories, but I believe we are working forward and trying to improve things slowly and improve awareness slowly.
I'm glad to hear
that. So just in closing, I'd just like to hear your thoughts as to what all of the patient groups with different diagnostics have in common that we've spoken about today, and get your perspective on these mechanical and anatomical considerations and how they're widespread.
Yeah, again, not to belabor the point, but I think the commonality that I find, whether it's a post-trauma, systemic inflammation due to an autoimmune condition, congenital connective tissue disorder, post-viral, post-exposure to molds and fungi, when imaged properly and confirmed, the commonality that I've found with all these patient groups is that they have anomalous motion, abnormal motion at the C1, C2 junction. So instability, basically.
Yeah, and I think it's very critical that you mentioned inflammation repeatedly. And when we talk about inflammation in the ME/CFS groups in particular and the other groups, we're seeing an approach to mast cell stabilization, addressing that this is a significant issue across all the patient groups, including some of the others that we've mentioned. So this is a therapeutic that's being addressed to try to control and manage these processes while we deal with causation, whether causation be infection or, as you mentioned, a biotoxin mold. And there's some great therapeutics that we'll talk about in the future. So if people do want to reach out to you, where would they find you, Dr. B?
Best is either to just navigate to whiplashclinic.com and or to drblaskovich.com. So drblaskovich.com or whiplashclinic.com. Those are the best places.
And some of the articles that we've talked about today, I've referenced on focusonhealing.ca. And we have linked you up in our few Canadian clinics that we recommend to people with this problem and complex chronic illnesses. So thank you for your time today and speaking with us.
My pleasure, Athena. Thank you for having me.